What joint it is? Anyone? This is a joint or something else? So it appears like a joint, right? Like a ball and socket joint, but it is not a joint. Okay. So this is a knee, this is ankle, but it is similar to joint. So the next question, just anyone tell me, if a fracture hasn't healed in 3 months, is it a non-union? Yes or no? Yes? Okay. So let's find out. So non-union is basically, it's not a broken bone, it's basically broken biology and broken mechanism. So for a bone to unite, we need two important things. We have to stabilize the fracture, that is the mechanism, the mechanics should be there, it should be stable. And the next most important thing, in fact this is the most important thing, is the biology. That is, bone is a vascular structure, it is a living tissue, so the blood supply should be there. So if something is missing among these two, then it can lead to non-union. So non-union definition is sometimes it's very arbitrary, there is a no fixed timeline, but the main point is, if a fracture has not united and you think it is not going to heal over the time, then it is a non-union. And on the other hand, delayed union is, yeah, fracture is taking time to unite, but it is slowly progressing to union. But in non-union, the progression has stopped. So US FDA has proposed a definition. So as per this definition, at least 9 months have passed since the fracture and it is still not healed, and moreover it has not shown any sign of progression for the consecutive 3 months. So there are 3 more important things: the 9 month, second is it is still not healing, and third is there is no progression to healing. Okay. So in consecutive 3 months you are taking radiographs, you are seeing there is no progression and there is no chance that it will heal. So basically a fracture that has no potential to heal is a non-union. So in delayed union, yeah, it can heal, but it is taking time. So I think you have a class regarding fracture healing. It goes through several stages. So to understand the non-union, you have to understand the stage of fracture healing. So it goes through inflammation, initial 7 days, followed by the callus formation, soft callus formation. There is an inflammatory cell, fibroblast, chondrocyte is there. So next 4 to 6 weeks, there is an enchondral ossification that convert to hard callus, soft callus, and then followed by remodeling. Okay, so these are the stages. So non-union stage is basically because of either failure of the biologic or because of the mechanism or mechanical. So it is because of the interrupted blood supply or because of the stability issues. So classification, there are several classification. So basically Weber and Check, they proposed a classification. So these are the 4 important variant: hypertrophic, oligotrophic, atrophic and pseudoarthrosis. So this classification is based on the, again, 2 important issues: whether there is a biology is preserved or not, whether there is a callus formation or not, and whether fractured tissues, fractured bone is stable or not. So hypertrophic means it is vascularized. Okay, that means the biology is preserved. So since it is vascularized, there is a callus formation, so healing has progressed, but still it has not healed because there was stability issues. Okay, so the fracture was not stable. Either there was no plaster or maybe it had needed operation or some kind of other plate or screw like nail. So though the blood supply is there, it has not healed because there is a stability issues. So this kind of non-union requires stability. So if you see the X-rays, see this is a humerus fracture, right? Just if you notice clearly, So it has not healed. See, you can clearly, this fracture line is visible, but see, there is abundant callus formation, right? So bone has, the callus has formed, that means there is a tissue is healthy, but still it has not healed because there is no plaster or like plate and screws. The second example, the surgeon has fixed the fracture, okay, he has applied the plate, but still it has not healed. Though there is a callus formation, see this beautiful callus. Why it has not healed? Because there is an implant failure. It's because of implant failure or because it has not healed, so the plate has broken. So the important thing is, though there is a callus, but the stability is not adequate. The next entity is oligotrophic. Oligo means the next to hypertrophic non-union. That means there is a callus formation, but it is not that much. So the biology is still there. Okay, there is some kind of mechanical issues also there. So it is because of both end, some kind of failure also biology and also mechanical issue. So yeah, the callus is there, little bit of callus, not much, okay, and it has not healed. The next is atrophic non-union. So this is important. The main important thing is their biology is defective, okay. So see, this is a humerus fracture, it has not healed, non-union, and there is no callus formation. That means the tissue has no ability to form the healthy bone, callus, okay. This is a femur fracture, it was fixed with a nail, okay. See, there is no callus formation, you can, the fracture line is visible. So the tissue is not healthy, it has no ability to form the callus. So this is the main issue, okay. And the first X-ray I have shown you. So this is pseudoarthrosis. So there is a callus formation, it basically forms a false joint, okay. There is a hypertrophic callus formation, and there is a over the time it forms a capsule, so it behaves like a joint. So this hypertrophic non-union, the biology is there, there is a callus formation is there, but stability is not there. Oligotrophic, little bit of callus, so it has, because of the defective biology and defective mechanical issue. Atrophic, the bone ends are atrophic, okay. So it is devascularized tissue, the bone can't form the callus. So this is the important concept you have to understand, okay. Again, among hypertrophic, there are the various names. Elephant foot, it is like a rounded and like a big elephant foot. Horse hoof, like a, the at the end of the horse leg there is a like hoop like structure. Oligotrophic, little bit of callus formation. Atrophic, the bone ends are atrophic, and this is pseudoarthrosis. That means this non-union site, it is surrounded by the capsule, the fluid comes and it behaves like a joint, and there is another entity that is infective. Okay, so etiology, if you want to understand the etiology, why there non-union happens, there are various factors. Host factor, the fracture factors, the factors because of the bone, some issues with the injury or bone, treatment related issues and infection. So if you go to the host factor, various issues like smoking, diabetes, nutrition, malnutrition, or any kind of medication, steroid, chemotherapy, poor bone quality, patient having osteoporosis, okay. So these all contribute to delayed bone healing and non-union, okay. Smoking is a established factor, also alcohol. So fracture related factors, okay. If it is a high energy injury, like motor vehicle accident, okay. If it is an open injury, open fracture means the fracture is communicating with the outside environment, it is contaminated. If there is a bone loss, okay, and there is soft tissue injury, that means the surrounding tissues are grossly damaged, devitalized, okay. So these factors can lead to high risk of delayed bone healing, non-union, and also infection. So fracture pattern, if there is a bone loss, segmental fracture, comminution is there, multiple fragments are there. So they have a high degree of soft tissue injury, surrounding tissues are grossly damaged, okay. So these are prone for non-union. Similarly, if there is a high velocity trauma, like motor vehicle accident, fall from a height. Okay, so there is open fracture is there. So there is a high chance of non-union. So importantly, again, it is not the bone only. We are not concerned with the bone. We are basically seeing the whole picture. Bone and surrounding tissues, all are important things. So to get the bone gets blood supply from the periosteum, from the endosteum. So if the surrounding tissues are ischemic, damage, so bone vitality is hampered. And also surgeon related factor. So if the surgeon is not very skilled, he has stabilized the fracture, but there is a gap in the fracture. And also if there is a relative stability, that means there is a excessive motion after application of the plate and nail, it is not that stable. So the bone has formed the callus. This important location you have to remember. Okay, scaphoid, metatarsal of the foot and femoral neck. These three bones, they have a very precarious blood supply. So these three regions are very prone for non-union. Even for the femoral neck fracture, the traditional time frame is 9 months. But for this femoral neck fracture, even 3 months. After 3 months, we can consider if the fracture has not healed, we can classify it as non-union. Okay. And also diaphyseal tibia fracture. In tibia, it is shin bone. It is like not that much of muscles, tissues. So it is prone for non-union. And also important infection. Infection is very notorious. So there may be gross infection, open draining wounds, erythema, inadequate soft tissue coverage, or infection could be subclinical. You get to diagnose with high ESR CRP values. So any kind of infection, it could be flagrant infection or subclinical infection, they can lead to non-union. When you evaluate the patient, first you have to start with the proper history, the mechanism of trauma, the mode of injury, the initial treatment, what kind of treatment he has received. The medical history is important because various host factors like smoking, diabetes or any kind of comorbidities, we have to control this factor to let the bone to unite. Then we go to physical examination. We have to assess the the limb, the soft tissues. We have to see the deformities. Then we have to go for the X-rays, imaging or CT scans. So we have to start with the proper history. History is really important. We have to identify the mode of trauma, the high velocity injury, whether it was open or closed injury, what kind of treatment he or she has received, conservative treatment or any surgical treatment he has received. Okay. Was there any prior infection to the fracture site? If it is an open fracture, previous open injuries, we have to inquire whether there is any discharging sinus or not. Okay. And what is the current symptoms? The pain, deformity or any kind of drainage from the limb. Okay. So this thorough history is really important to identify the cause of non-union, so that we have to control those factors. We have to if they are modifiable, we have to modify those factors and to help the bone to unite. And we have to see what kind of problem the patient is facing, so we can improve his quality of life. Then medical history, we have to see whether he has all these comorbidities, any kind of malnutrition, whether he is smoking, any medications. So this history, these comorbidities, these are important and we have to address these things. And then physical examination. So established non-union has abnormal mobility. So if suppose a tibia non-union, you can move the fracture site, non-union site in both planes. Okay. Now tenderness. Ideally in non-union, that is aseptic non-union, there is no tenderness. Okay. So once you palpate, there is no bony tenderness. But if it is an infected non-union, then you get to see tenderness. Okay. This important differentiating point. We have to see the limb, examine the limb regarding color, the skin quality, whether there is any prior surgical incision or not, okay, and any kind of infected draining sinus. We have to identify, we have to examine the joints. This is important for the treatment purpose. Okay, what is the range of motion of the joints? So many times we see patients like the patient has received multiple treatment for the tibia non-union or any kind of non-union, and we see that like knee is totally stiff. He can't move the knee or shoulder or the joints. So we have to address these things. Importantly, we have to note down and document the vascular status and sensation. This is really important, not only for the treatment purpose, for the medical legal issues also. And we have to examine the deformity, what is the limb length discrepancy, the alignment and rotation. So this thorough examination is important for documentation, for treatment purpose, for treatment planning. Now imaging. So we start with the plain radiographs, and sometimes we get CT scan to delineate the anatomy of the non-union site and other relevant details. So healing of 3 out of 4 cortices in the X-ray is considered union. So when you see the X-ray, it is a 2D image basically. So you get orthogonal X-rays, you know, AP view and lateral view. So basically you are seeing 4 cortices. So if you get to see healing of the 3 cortices, then you can assume that the fracture has united. Okay, and if you have any difficulty in like delineating, then you have to get the CT scan. I would like you to note down or remember this 9 X-ray findings. Okay, this approach. So this is basically a comprehensive approach to help you to note down all the important details that you need to document for the treatment purpose, to understand the type of non-union, to understand the nature of the non-union, and for the treatment planning purpose. So you see number of views. You get at least 2 perpendicular view, AP and lateral view of the limb. Non-union site, you identify the non-union site, what is the point of focus, type of non-union, okay, whether there is callus formation, that is hypertrophic non-union, or it is atrophic non-union, okay. Then bone loss, you have to identify whether there is the continuity is there or not, whether there is significant bone loss, significant shortening is there or not. Deformity, you get to see the deformity, angulation or any kind of deformity, coronal or sagittal plane deformity in the X-ray. And also quality of the bone, whether bone is osteoporotic or not, because if the bone is osteoporotic, then you have to take extra precaution during fixation or in post-operative period. And what are the current fixation, that means is there any metal part implant, any plate or any nail inside the fracture site, non-union site, whether it was operated before. And the joint, always in orthopedics examine the one joint above, one joint below, okay. So this important thing, they give you the whole picture about the non-union and help you to understand the pathology and help you to plan treatment. And importantly, because it is a chronic problem and sometimes treatment is really frustrating, so you have to discuss the expectations, what you are expecting, how much time you are expecting that it will take time to unite the fracture, and what is the like your vision, your expected outcome. So you have to explain everything to the patient. So now treatment principle, again back to the basic. So our goal is to unite the fracture, okay. So to understand what treatment we will like adopt, again we have to understand the non-union type. So if it is a hypertrophic non-union, that means, again I am repeating, the biology, the bone ends are viable, the biology is intact. So main problem is mechanical. So we have to give the fracture some rigid fixation. So bone grafting is not required because the bone can form the callus. Okay, so we have to just, if there is a fixation is not adequate, we have to put some rigid plate or some rod inside so that we can give the stability to the fractures, non-union side. On the other hand, atrophic non-union, that means it is not viable. The blood supply is not adequate, it is like some biology is hampered. So here there are two issues, poor biology and mechanical instability. So what is important? We have to, since the bone can form the callus, we have to supplement, we have to facilitate the bone so that it can form the callus. How? We put the bone graft or any kind of bone graft, is autograft or some kind of bone substitute or like vascularized bone graft. So hypertrophic non-union, you have to fix it. Atrophic, you have to fix it and also fill it. You have to put the bone graft or any kind of substitute that can facilitate bone formation. So in general, there are two kinds of treatment, non-operative and operative, though non-operative treatment has limited role. In non-operative treatment, various kind of electrical stimulation, ultrasound, extracorporeal shockwave therapy is there. Also in renal stone, you use this therapy, right? So basically they are, in isolation, they are not very helpful in uniting the fracture. They are helpful in delayed union, but once it is an established non-union, they are not very helpful. Okay, so we have to address the main issues, either bone graft and fixation, and then you can use those issues. Now the main treatment is operative. What are the operative treatment available? Debridement. If it is infection, you do thorough debridement, and if there is any metal implant is there, you remove the hardware. Then either you do plate osteosynthesis, that is plate fixation, or intramedullary nailing. That means in long bone like tibia, femur, you put the nail. But whether you are choosing the plate or nail, it depends on it is like beyond your I would say MBBS curriculum. Like you have to understand the implant mechanisms to understand where you are putting plate or nail. So the basic is you have to fix the fracture, and external fixation is there also. And there's the various kind of bone graft, autogenous bone graft, I will discuss this later. Various kind of bone marrow aspirate, allograft, and BMP is bone morphogenetic protein or platelet rich plasma. So surgical treatment, again hypertrophic non-union, you can, depending on the fracture non-union type, location, either you are putting the plate, so you expose the fracture site, you debride all the fibrous tissue, unhealthy tissue, and then put the plate and fix the fracture. And similarly in nailing, you ream the medullary canal. So reaming has a very good influence on the bone healing because it stimulates blood flow and provide a tight fit. You can put a more thicker nail. So in hypertrophic non-union, you can adopt either plating or nailing. So again the focus is on the rigid fixation of the fracture. So in atrophic non-union, what you do? I told you in atrophic non-union the issue is biology. So the bone ends are atrophic, sclerotic. In a sclerotic region, so they are not viable. So you have to debride all their non-viable tissue, sclerotic bones back to the bleeding bone. So we have to get a healthy bone margin. Okay, so that suppose it is a region of the non-union atrophic site, so you have to remove all the sclerotic region so that you get to see the bleeding bone. So that you can then you can be confirmed that this is the healthy bone. Now we can fix the fracture. Okay, then you do the fixation and the grafting. You have to fill the fracture's non-union site with some kind of bone graft. Okay, so it could be cancellous bone graft or any kind of bone substitute. So debridement is the very critical step. So bone can't heal if the bone ends are sclerotic and non-viable, and you have to fill the non-union site with some kind of biological material like bone graft. Okay, So I hope you understand this important difference between hypertrophic and atrophic non-union. And these are the very advanced reconstruction philosophy. You can note down the name Muscale technique, we call it induced membrane technique, or Elizarov external fixator. Okay, so these are employed if there is an infection or deformity or bone loss. Okay, then we use this kind of advanced reconstruction modalities. Again, infection, the main mantra is always thorough debridement, debridement, debridement. Get the cultures so that you can start the appropriate antibiotic. And also importantly, infected non-union also requires stability. So for the bone to unite, you have to stable the non-union to bone fragments. Okay. Now coming to the bone grafting. Okay, so to understand the bone grafting, you have to know these three important terminology: osteoinductive, osteogenic, and osteoconductive. Okay, so ideal bone graft should have all these three characteristics. So what is osteogenic? That means the bone graft has some stem cell, osteoblast or progenitor cells. So the bone graft itself can form the bone. Okay. What is osteoinductive? That means the bone graft has some kind of proteins or growth factors that induce bone formation and also vascular ingrowth. Okay, so it induces. And what is osteoconductive? This bone graft, it provides basically a scaffold, a platform over which there is a formation of the bone. So ideally, autogenous bone graft means the bone from your own body. What are this is considered the gold standard, because ideally autogenous bone graft from the iliac crest or any kind of cancellous region from distal tibia, they have all three characteristics. So they are basically ideal for sorry, non-union, or where there you need to put the bone graft. So again, autograft is a gold standard. You take the bone graft from the patient's own body. So it has all three characteristics. Common sites are iliac crest, distal tibia or proximal humerus. But the only disadvantage is it has donor site morbidity, because you are taking bone graft from iliac crest or maybe distal tibia. So some kind of deformity, donor site pain, they will remain. What is allograft? Allograft means, the name suggests, it is from the other donor, not from the patient. Okay. So from the other donor, you have to process the bone graft, you have to make it sterile, and so that you have to make it less immunogenic, so that you can, it's like a kidney transplant or any kind of transplant. If you are taking bone graft from other patients and you are processing it and then implanting to other patient, so naturally there are risk of infection, and in the processing phase you lose osteogenic potential. That means you can lose the stem cell progenitor cells. So this allograft, they has no osteogenic properties. Yeah, they are osteoinductive, osteoconductive, but not osteogenic. And bone graft substitute, like synthetic bone grafts or any kind of substitute, calcium sulfate substitute, calcium phosphate substitute, they are basically they are osteoconductive. They provide only scaffold. Okay. And finally, this adjuvant therapies, there is various biological agent. We frequently use platelet rich plasma. We take the blood from the patient, centrifuges. After centrifugation, we prepare the platelet rich plasma. So this plasma is rich in growth factors, and these growth factors helps in bone union. And also bone morphogenetic protein, this is really new. Okay, so this is very expensive, and sometimes we have to put this bone morphogenetic protein to help the bone to unite. And other modalities like ultrasound, electromagnetic fields, they also help facilitate bone union. So I guess this is all. So again, I am going back to the first slide. So this is not a joint, this is a pseudo arthrosis, right? So it is like a joint, it is a non-union site, hypertrophic non-union, callus is there, and there has been a capsule formation, fibrous capsule. So it is giving kind of it is very mobile region, it behaves like a joint. And 3 month, yeah, 3 month is not the timeline, it is 9 month. But in some region like fracture neck of femur, it is usually 3 months. Okay, otherwise you have to wait for the 9 months. And so the 3 important features is the 9-month timeline. Second is there is no progression of the healing for consecutive 3 months, and third is there is still fracture has not united. So then you can classify it as a non-union. So suppose a fracture, a patient comes to you with a tibia fracture, the patient was treated with a cast plaster. Okay, so it comes at the time of maybe 5 months. Okay, so then you get the serial X-rays every like 3 to 4 weeks. You get the X-rays because 5 months is early. Okay, so you get the X-rays. If you observe that it is progressing, there is a bit of progression to the union, then it is a delayed union. It is not a non-union. Non-union is the fracture has not united and it is not going to heal. So you have to intervene. Okay, so if it is established non-union, you have to do something. So the main important types are hypertrophic, oligotrophic, atrophic, and pseudoarthrosis. Okay, and you have to address the mechanics and biology. Okay, your whole treatment is basically centered around these two issues. And during X-ray examination, if you do it systematically with the rule of 9, so you can get a comprehensive picture of the condition of the patient, condition of the non-union, and depending on the non-union type, if it is a hypertrophic non-union, you provide good stability. If it is atrophic non-union, you have to provide stability plus biology, that means bone graft. And in bone grafts, autograft is the ideal choice. Yeah. So that's all. I think it's not difficult, right? Huh? Did you understand the basic concepts? Okay. So all these advanced like treatment philosophies where you do plating like Ilizarov and nailing, you don't have to think like this because you have to understand the concept. Okay. So what kind of non-union it is, what kind of X-ray picture you would see in the X-ray, and in what line you are going to do intervention. See the X-ray picture. Okay. So hypertrophic is there is a callus formation, oligotrophic little bit of callus, and atrophic there is no callus. Okay. And if you remember this picture, then the treatment philosophy will be clear to you, and the whole picture of the non-union, right?